Have you ever worn a CGM, a continuous glucose monitor? I have. I wore one a couple of years ago and was fascinated with the data that I learned about myself. So I'm excited to introduce to you my guest today. Dr. Paul Kolodzik is a double board certified emergency and metabolic health physician with 30 years of experience. He is board certified by the American College of Emergency Medicine and the American Board of Preventive Medicine. Dr. Paul Kolodzik graduated from the University of Notre Dame and attended the Wright State University School of Medicine. He then had his residency in emergency medicine in 1987, serving as chief resident in his final year. He has served as a clinical faculty at the Ohio State University School of Medicine and has been an assistant clinical professor at Wright State University. As a private practice metabolic MD, Dr. Kolodzik has used continuous glucose monitoring CGMs to help thousands of patients to lose weight and to prevent and reverse disease. In his book, The Continuous Glucose Monitor Revelation for Non-Diabetics, love it, Dr. Kolodzik presented a comprehensive program for metabolic health using CGMs. Dr. Kolodzik, welcome to the show.
It's great to be here. Thank you for having me, Carol.
Oh, you're so welcome. I'm excited to dive in, but before we do, how did you move from the ER to metabolic medicine and being in private practice? What prompted this?
Yeah, so it's not that illogical when you come to think about it, but I spent 25 years in the emergency department, and what gets all the press in the emergency department is the overdoses and the traumas. Um, but really, what emergency physicians see day in and day out, all day long, I actually am still working a shift a week, and I worked yesterday, is vascular disease. People that have medical problems from being overweight and having vascular issues. Vascular issues are blood vessel lining issues. And the common denominator of obesity and those vascular problems is high blood sugar. Because high blood sugar, of course, leads to obesity. We can talk about the physiology of that. And it also leads to the problems, again, we see in the emergency department: the kidney failure, the peripheral vascular disease, the heart attacks, the strokes. There's a relationship between these. And, blood sugar and insulin resistance is the primary problem that leads to those issues for most Americans.
I would agree. And I assume you've been seeing a steady increase in this over the decades.
Oh, absolutely. I mean, you kind of teed me up with that question, and we'll get into this. And our philosophies may not exactly align. We'll have to talk about it. But my personal belief is that we were doing fine until the food pyramid came out in the 1970s, and we were overnight told to change our traditional diet, which was 25% carbs, 50% fat, and 25% protein. Overnight, we were told to switch the carbohydrate and fat components, and we were told to eat, according to the food pyramid, 50% carbohydrates, 25% fat, and 25% protein. And of course, you want to push the protein a little bit higher if you can do that. But what happened then is, and I think this is unmistakable, those guidelines came out. Food processing industry kind of jumped on board because profitable foods are refined grains, refined wheat, seed oils, the bad oils, and sugar.
Mhm.
And so, there was this perfect moment where the government's food guidelines and that process from the food industry came together. And what happened then? The epidemic of obesity took off. It's unmistakable if you look at the curves. Food pyramid comes out and the obesity curves start rising. And then, as you would expect, 10 years after that, after we got overweight as a country, then the diabetic epidemic started, and those numbers started rising. So when we talk about using CGMs, and I use them to guide low carb diets, we're really just going back to the way we ate for really generations before we were told to do otherwise. If you look at, movies or photographs from the, 40s and 50s, you don't see the obesity that we have today. And I believe that that's the history as to why we have significant obesity issues, diabetic issues, and then all the vascular problems that go along with that.
I am in agreement with you. I remember that whole craze of low fat, and everything on the package, low fat. Well, then what went up? What, refined carbohydrates, refined sugars. And like you said, you can see that if you look on a graph, you can see that data and what happened as a country.
Absolutely. I think it's unmistakable. So, really, I think, to be successful, you have to address that by reversing that macronutrient intake. And that's what my patients are able to do.
Yes, I agree. The food pyramid was, I remember that was one of the worst things because it did encourage this consumption of so many grains. And I don't think people understand when they're having that many grains, that many refined carbohydrates, it is like eating just sugar.
Yeah, yeah, it's here. People, we'll talk about this if you want to. The physiology. It's people don't understand. Even diabetics don't understand often that when you eat a carb, it basically becomes blood glucose in your system immediately. I mean, there's the fiber component, which does not do that. It passes through you. Fiber is good. I tell my patients, fiber is free. You don't have to
Hmm.
count the carbs associated with the fiber you eat. But sugar obviously gets ingested and becomes sugar, blood glucose in your system. And then the carbs immediately, when they cross the gut wall, become primarily blood glucose as well. And people, I think people are beginning to understand that. Low carb isn't a phase anymore. It's not a fad. It's been around now 30 years. But one of the main things I do is I help educate people that carbs become blood sugar, and then we talk about the physiology of that.
Right. And I assume too, getting them to eat the right type of carbs and perhaps timing in there as well. Do you look at the timing of
Absolutely.
carbs?
Absolutely. Yeah, the sequence with which you eat your carbohydrates matter. Can we talk for a second just kind of about I have kind of like a very simplistic approach to why people gain weight on high carb diets and things like fatty liver disease isn't caused by eating fat, it's caused by eating carbs. Can I talk about that for a second?
Absolutely, yes.
Okay. So this is what I share with my patients, and I try and simplify it so for my own understanding, but also to help my patients. And really, when you eat a carb, the fiber carbs generally consist of a food that is carbohydrate consists of sugar, um, complex carbohydrates, which basically are sugar molecules that are linked together into large bundles, and fiber. Fiber passes through you, sugar gets absorbed as sugar, but the complex carbohydrates then get broken down in the gut wall and they get absorbed as sugar. There's this term insulin resistance, which people are becoming more familiar with. And the simple explanation of what that is that if you eat a complex carb, your blood sugar rises. At that point, the pancreas releases insulin, which is like the key in the lock to drive that blood glucose into your organs. And when I'm talking about organs, I'm going to use the example of muscles. Muscles need energy. That blood glucose is being forced into the muscles to go ahead and use that energy for muscle contraction, things we need it for. So far, so good. But when the blood glucose is elevated extensively for long periods of time, which is what happens on a high carbohydrate diet, then after a while, those muscles say, we got all the energy we need here. We've absorbed a lot of energy. We don't need any more blood glucose. So, what happens with that extra blood glucose? Well, it goes to the liver and gets converted to fat, like we talked about, and then it gets deposited in the body, primarily around the middle, but all over the body. And that's why people gain weight on high carbohydrate diets. What happens after a while is the muscles and the organs say, we got as much energy as we need. We don't want any more. We aren't going to listen to you any more insulin. We don't want to absorb any more blood glucose. So that's what insulin resistance is. It's basically the organ saying, insulin, we aren't going to listen to you anymore. But the pancreas doesn't get the message. It keeps pumping out insulin. The insulin levels get higher and higher. And so that's the scenario of insulin resistance. What we try and do with a low carb diet using continuous glucose monitors to guide that diet is lower that blood glucose over a period of time. And then after a while, those organs, those muscles that still need energy are looking around saying, hey, we need energy here. We want some more blood glucose because that's their preferred energy source. But there isn't as much blood glucose around because the person has gone on a low carb diet. So then what happens? Those organs start looking around and say, we need another source of energy. What's that going to be? And it looks down around the middle of the body with these big fat stores we have here and say, that's going to be my source of energy. And that's when you start breaking down fat, you start reversing that process. The fat becomes the energy source, and that's when you start losing weight. So this is the insulin resistance model of low carb diet weight loss, which I think is much more effective than the calories in, calories out energy expenditure model, which I don't think is sustainable for a lifetime.
Oh, I could not agree more. And that was a beautiful explanation because it is, people get confused. They don't quite understand what is insulin resistance, what causes this weight gain, what can I do to lose it. I work with so many women over the age of 50, and we start to see this problem, this blood glucose dysregulation. Is that something you see a lot in midlife women?
Oh, an awful lot. And as you mentioned, it can be significant if you're overweight when you're younger. Menopause and the hormonal changes that occur there kind of spur that, and it makes it tough. And, people come in and they say, well, I can't lose weight. Well, you can't lose weight because you've got insulin resistance. And until you reverse that insulin resistance, it's going to be very difficult. And, the playing field's not fair. It's easier for the guys because they don't have those hormonal changes. And then it's more difficult, the older you get as well. So, to use a continuous glucose monitor to kind of, first of all, make you aware of that and then guide your diet, I think is a great approach and really what I've been doing now for 7 years. So can I tell you a little bit about the process? I do a trial with people where we use a CGM for a couple weeks. Yeah, okay, if I talk
Yeah,
about that?
absolutely. Yes, please
Okay.
do.
All right. So when patients come to me, the first thing we do is we want to do a diagnostic assessment, and I use the CGMs. We call it a 2-week trial, and we put a CGM on patients. For patients that aren't completely familiar with these continuous glucose monitors, there's the devices you see on the back of the arms of diabetics, initially developed to guide insulin regimens, but I think tremendous tools for non-diabetics and a tremendous tool to help reverse pre-diabetes completely and also lower insulin requirements or medication requirements in diabetics. So we put a CGM on them. They don't hurt. They last 2 weeks. You sync it to your smartphone, and then you can see your blood glucose readings 24/7 in real time. And that 2-week process for some people, I mean, I don't want to be too dramatic, but sometimes just seeing those curves can change people's lives. They have not seen where their sugar is. They think they're fine. Oh, they're spiking to 170, indicating they're pre-diabetic, or they're spiking to 220 where they didn't know they had any problem, indicating they're diabetic. And as my patients have put it, once you see those curves, you can't unsee them.
Hmm.
Once you see what a piece of pizza does or a donut does, it can be very motivating just because knowledge is power. And they now know what their food consumption is doing to their body. But during the 2-week phase, I tell them not to change your diet. Let's just gather data for 2 weeks, see where you are. The other thing we do, and I don't know if you've talked about this on your program, we do a critical test, which is a fasting insulin level. Have you guys talked much about that at all?
I've touched on it in the past, but it's been a while, so this would be really good for the listeners to hear.
Okay. So I think fasting insulin levels are absolutely critical. We've gone through this phase of cholesterol is the end all of, metabolic health. And for the vast majority of patients that come into my office, remember, they're self selected because they're overweight to begin with and they want to lose weight. But their insulin resistance is much, much more important in terms of their long term health than their cholesterol level is. I think a lot of things have happened with cholesterol and the emphasis on cholesterol, and of course, the pharmaceutical industry on saying this has to be treated and people need to be on statins. And I'm not anti-statin. Some people do need to be on statins, but for the majority of my patients, in terms of vascular injury, two main components: high blood sugar and cholesterol. The insulin resistance, the high blood sugar issue is much, much more significant. So I draw fasting insulin on every patient, and you can drill down to an exact level of insulin resistance by doing that. You measure a fasting insulin level, and then you measure a simultaneous blood glucose. Those two have a relationship because if your insulin level's up a little bit, it should be driving your blood glucose down because it should be driving that blood glucose into your organs. Now, if you've got insulin resistance and that insulin has kept going up because the organs don't want to listen to the pancreas and the insulin that's being released, and you've got a high insulin level, then you have insulin resistance. So you can plug these two numbers into a formula, simultaneous fasting blood glucose and insulin level, and you can calculate an exact level of insulin resistance. So the most important thing I do for my patients during this 2-week phase is calculate a level of insulin resistance using that calculation and then doing the CGM. And we check lipids as well, and we check, thyroid function and all, the routine things. But by far and away, the most important thing I think I do for patients early on is let them see their CGM curves and then calculate their exact level of insulin resistance.
Now, number wise, what are you looking at in the numbers with this for the labs?
So insulin levels generally go from about 5 to 20. I'm looking for an insulin level that's under 10. Okay, 5 to 20 is the normal range, but when you get toward the higher normal range, you've got some insulin resistance. And then again, you can plug those two numbers. Fasting blood glucose for most people, the standard in medicine is if you're under 100, it's okay. People have insulin resistance going on years before their fasting blood sugar gets to 100, or a diabetic range is 125. And you can determine that you have insulin resistance. Most metabolic health physicians believe insulin resistance starts 5 years before you become pre-diabetic. And so it's very helpful for people to get a handle on. The other thing you can do is pick it up with the CGMs that people are spiking high. You may have a morning blood sugar that's under 100, indicating no prediabetes, but then you got a CGM with a spike of 180, indicating you have insulin resistance. And in fact, that is criteria for prediabetes. It's just more valuable information to educate yourself on and then act on.
Absolutely. Now I know you work primarily with people who come in to lose weight. How difficult is that? Not just for the weight loss, but to reverse the insulin resistance, like time wise and with the addictive nature of food. How difficult
Right.
is that?
I'll tell you, people do really, really well. I mean, once they have data, so we go through this diagnostic phase with the CGM, and then most of my patients use a CGM either continuously or intermittently for 6 months after that. And that's basically what I call the therapeutic phase. So we talk about what are your carb limits going to be? What's your macronutrient mix is going to be? How much protein do you need to get? And the CGMs then over that 6 month period of time guide their diet. And I can see that data remotely as well. So a lot of people quite honestly want that accountability. They want somebody that's keeping an eye on them. And if they go out with their family for Friday night dinner, I don't they don't get a phone call from me. But if things are going off the rails over 4 or 5 days, then they're going to hear from me or one of my health coaches. So the CGMs then are used to guide diet. And the low carb piece is not the only piece. The components of, I think, an effective program to lower insulin resistance and what I do with my patients are the low carb approach. And basically, we generally look to get people, the typical Americans can come in and that they could be eating 300 grams of carbs a day. So I usually generally target, I found it's easier to kind of rip the band-aid off quickly rather than, oh, we're going to lower to 150 and then we're going to lower to 100. And so we generally go to 50 to 75 grams. And then after that, usually under 50. And then we push the protein. I don't care that much about fat, quite honestly, with my patients. Again, because basically I suggest, let's get this much protein in. Let's keep our protein over 100 or 125 grams a day. Let's get our carbs under 50 a day. And then let's eat good fats, but let's not really worry about the amount of fat you're getting. And let's not worry about your calories. It's really just, let's target the carbs and the proteins. And then there are other components of a plan like this to be effective. Other tools to lower insulin resistance, intermittent fasting. I'm sure you have talked about that a fair
Mhm.
amount.
Yes, yes, quite a bit. I am definitely a fan of intermittent fasting when it is applied correctly.
Yeah. And that's what we do. So it's low carb targets using a CGM, and then it's intermittent fasting. And I'm not asking people to fast for 36 hours. Some people, they come in and their biggest fast is 8 or 9 hours overnight. So we'll do 12 hours and then we'll do 14 hours. A lot of my patients are just on 14 hours or 16 hours a day fasting. That's the vast majority of my patients. Some people want to do a one meal a day thing, and that's fine. But it's like, let's just get to 14 or 16 hours. And then the third component, and again, this doesn't have to drive your life. You're going on vacation. Things don't need to be so strict. You can enjoy yourself. You got a special family occasion, or on Saturday morning you want to go out to breakfast with your family. That's fine. We'll work around that. We just need some general guidelines that are applied the majority of the time. And then the third component, very much, and I know you've talked about this. I don't know if you've talked about it specifically related to insulin resistance, but the third component is strength training. Because and I know I know your background, so I know your interest there. But a lot of people don't realize that strength training decreases insulin resistance. When you increase the size of your muscles, you increase the quality and receptivity of those insulin receptors on your muscles. They're going to soak up more insulin. Cardio doesn't do that to the same extent. I do believe in cardiac fitness. I believe people should follow the American Heart Association guidelines for cardiac fitness, which we can talk about. But I really want people spending the majority of their time doing strength training. And for your population of clients, the middle-aged women, there is the osteoporosis issue that's going to be putting them at risk, which of course strength training, and I'm preaching to the choir here, I know strength training counteracts. The value of strength training, especially for middle-aged and older women, is tremendous. And so it's like that's where the emphasis should be as opposed to cardio. And one reason for that emphasis is that it's decreasing your insulin resistance, and it's going to help you lose weight and meet your health goals as well.
Absolutely. I am so happy that you dove into this. You made, some really good points here. So the protein in complete agreement. I do the same with my clients because I find that if they hit their protein goal with quality protein, it crowds out a lot of the other junk because it's so
Absolutely.
satiating. Yeah, it
Yeah.
just, the carbs and fats tend to work themselves out a lot more if they hit that protein goal. I
Yeah.
love that you touched on, hey, enjoy your family and your vacation because this has to be a lifestyle. It has to be sustainable. And then
Yeah.
the strength training, oh, I am constantly saying it should be non-negotiable. Like it's
Yeah.
almost irresponsible not to do it.
I, I agree. I actually do TikToks. I did a TikTok, and I got like 1.2 million hits on get off the expletive cardio machines. And of course, I didn't mean completely get off the expletive cardio machines. The AHA guidelines, which I touched about, the American Heart Association guidelines, and I'm not in favor of everything they do because unfortunately the AHA is sponsored by a lot of uh, food companies
Seed
that do a lot
oils.
of process. Yeah, absolutely. It's crazy that the AHA should, is taking money from those kind of organizations. So, you got to be careful here. But, I'll go with their guidelines, which is, you're probably familiar with this, 150 minutes a week of cardio at 65% of your maximum heart rate. Okay, which is, get on the internet, it's easy to calculate 220 minus age, and then take 65% of that, or 75 minutes a week at 80%, 85% of your maximum heart rate. And of course, that's my preference. That's what I do personally. And the reason is because we all have limited time, and you need to be spending most of that time you have in the weight room, or bands, Pilates, whatever, body weight, whatever approach you want to take, free weights machines. um, but you want to reserve the vast majority of your workout time, 4 or 5 hours every week or whatever you have. I know for you it's a lot more than that, but for most people, you want to reserve that time for strength training. So get your cardio out of the way. For me personally, 3 25-minute sessions where I get my heart rate to 85% of my max, and then I'm done, and I can spend the rest of the time focusing on making sure I'm maintaining my muscle mass and decreasing my insulin resistance.
Oh, could not agree more. That's my focus in the gym, of course, is the strength training. I like zone two cardio. I find it almost relaxing and stress relieving. So I do quite a bit of that. And then just a little bit at the higher intensity. And it is perfect. I
Yeah,
see so many women, I'm still seeing this where they go in and they head right for the cardio. And I've watched them age over the years, and you can see that decline in muscle, the
yeah.
stooped appearance, and they won't ever head into that weight room.
Yeah, yeah. I mean, and again, I have a lot of women come to me and they've never lifted a weight in their life. So let's move into this gradually. I mean, I have patients where I say, okay, let's do a squat. You know what a squat for you is going to be to start? Sitting down in a chair and standing up 10 times, and let's get some 5 pound weights just to start. We give all our patients a set of bands as well. Some of these patients are not been in gyms and they're a little bit intimidated by that. So let's put a program together where you maybe use body weight and some light weights and some bands at home, and we'll get you in the groove. And if you want later on, you can graduate to it to go into the gym. Um, and people, with this combination of activities of, lower carb, higher protein, intermittent fasting, and strength training, but people invariably make progress. People, and then that you have the CGM on that's motivating you. So, quite honestly, one reason I'm doing this is because it has a big impact on people. And I don't know any other way. I know no other way that's more effective than this for people to achieve their health and weight loss goals.
Oh, I think it's excellent what you're doing, and how you're educating people, because that's key. People need to understand the why, and then that makes a huge difference, I've found. And then those numbers, seeing what happens, like when you eat too frequently, because
Yeah.
Americans, they snack. I think I'd heard like 9 to 11 times per day for many Americans, because it's a little of this and a little of that all day long. And that's where that intermittent fasting, kind of spacing out those meals. And I love, you said 14 hours. That's typically what I do, sometimes 16. And it's,
Yeah.
it's made a big difference.
Well, and we've been told the opposite. We've been told breakfast is the most important meal of the day.
Oh, yeah.
You need to eat your, 35-gram carb sugary cereal in the morning. And we've been told, oh, to be healthy, you got to eat 6 times a day. You got to be snacking. that this is just these are just things that were made up out of the air, um, to sell food products and
Mm-hmm.
processed food. And when you really drop back to really what Americans did for many generations, and if you want to extend that, you can even talk about going back to the paleo era. We're just going back to the way things are supposed to be before we were miseducated in this regard. I tell my patients sometimes regarding the intermittent fasting, it's like, that's the way it was for humans
Mm-hmm.
thousands of years. You would have a great harvest and you would feast, and then there would be maybe not a couple good years, and you would have a famine, and you would be fasting during that time. Or if you were a cave family, you'd go out and you'd kill a woolly mammoth, and the hunt would be good, and you would feast. But then maybe you couldn't find another meal for another 3 weeks. I personally believe that kind of pattern maybe carried to an extreme back then, and of course people didn't live as long. But emulating that a little bit with some intermittent fasting, I think, is just a smart thing to do. And there's no question it drives down insulin levels. Intermittent fasting drives down insulin levels, and what does that do? Makes it easier to lose weight.
Yes, absolutely. And even just the digestive rest is important. We need that time.
Yes,
We can't be eating every hour on the hour. I came
right,
from the into this from the bodybuilding community. That was kind of my
right,
my start into fitness. I did shows, and we were taught rev up your metabolism with 6 to 7 meals per day. And
yeah,
I look back and it's like, okay, it worked because it was very low carb and all the foods were whole foods, but
yeah.
when I came out of that lifestyle, I had a tough time reversing that need to reach for something every 2 hours. It was tough.
Right, right. And you kind of alluded to the healthy eating component. If we could touch on this, um, so regarding the carb intake that you have. First of all, I'm going to say something that might not everybody might not agree with, but Mom told us to eat all our fruits and vegetables. But 40 years ago, the fruits were different than they're now. They're genetically engineered to be high fructose, very palatable foods. So you got to be very careful with your fruits. You can't just eat a pineapple and think, oh, this is a fruit. It's good for me, because they are packed with sugar now. If you're eating fruits, opt for the berries. Blueberries, strawberries have a tendency to be a better option. And then regarding vegetables, you should seek out those vegetables that are higher in fiber, because the fiber in those vegetables helps slow the digestion and the breakdown of the complex carbs, which become sugar. This has a little bit to do with the sequence of eating your food that you alluded to when we started talking here. But you want to seek out foods that are vegetables that are high in fiber. Obviously the leaf vegetables, the broccoli, the Brussels sprouts, that kind of stuff, as opposed to what are often considered vegetables, which are really significantly starchy foods with complex carbohydrates. And I'm not saying you shouldn't have carrots or a potato once in a while, but you got to be a little bit careful. And then the foods that are made from refined grains, you got to be really careful with. We're told whole grains, and whole grains are better than completely refined flour, but whole grains still can have a fair amount of carbs in them, so you got to watch that carb intake.
You hit on some points here. I really want to back up and unpack. You're the first person to say this with the fruit. I had not heard genetically engineered so that they are hyper palatable and very
Yeah,
high in sugar. That's the first time I had heard
yeah.
that.
Oh yeah.
Very interesting.
You put a CGM on and you eat a pineapple from the store, and you'll see that. I mean,
I bet.
some of my patients see some of their highest spikes, and it's just again, it's not. I mean, we think of fruits and the typical eat all your fruits and vegetables, but those fruits, the fruits today are not like they were 35 or 40 years ago. They're packed. And, fructose in particular, which of course, fructose corn syrup is what's put in, most of the sugary beverages. In fructose, a lot of fructose in some of those hyperpalatable fruits, as you put it. They can really spike your blood sugar. And fructose is now becoming believed to be one of the primary reasons for fatty liver disease as well. So, you got to understand that fruits are primary. I mean, fructose, there's a reason they're called fruits. And so you got to be, careful with those.
Oh, yes. Yes, absolutely. I've been hearing some interesting things too of the connection with uric acid and high fructose levels. It's
Yeah.
really fascinating, some of the new information
Yeah.
that's coming out on that and how it can cause you to store fat and make it
Well,
virtually impossible to get rid of body
yeah.
fat.
Yeah, your body wants you to be fat. If you were alive 200 or 300 or further years ago, then that confers a higher likelihood of survivability. Women have more fat under their skin, subcutaneous fat, than males. There's a reason for that because they bear children, and that survivability is important. But basically, blood sugar, as we discussed, excess blood sugar goes to the liver and gets converted to fat. It's the reason for fatty liver disease. I did another TikTok. Is that fat doesn't cause fatty liver disease, again, because carbs do. And if you can reverse that process where your body's seeking fat as a source of energy, you can reverse, not only obesity, you can reverse other disease like fatty liver disease. And then can we come back to the vascular discussion, the blood lining?
Yes, yes.
So again, one of the reasons I kind of came to this is because, diabetic, kidney failure and peripheral vascular disease and strokes and heart attacks, and that results from an inflammatory process of your blood vessels. So the biggest component of that, I believe, in the United States is what's called, fancy word, glycosylation, which simply means glucose molecules are attaching to the blood vessel linings. Okay, that glucose, when it's high, attaches to the blood vessel linings, and it causes inflammation. And that's what sets you up for plaque buildup. Yeah, does cholesterol come along and play a role? Yeah, it does. But my belief is, and I just think it's true, that the bigger issue really is, the blood sugar inflammation that occurs. And then that's what ultimately leads to these different vascular problems that I see in the emergency department. The other thing, which is now becoming, I think, increasingly verified, is that blood glucose doesn't only attach to your blood vessels, it attaches to other organs. One of those organs being the cartilage that's in your joints. So high blood sugar also causes inflammation of the joints, resulting in musculoskeletal and joint pain. And I have, many patients that once, their blood sugars go from, averaging 140 over a 24-hour period to averaging 105, their joint pain decreases very, very significantly. And the party line always has been thinking, well, if you lose weight, of course your knees are going to hurt less, and that's true. But people have, I think, a decrease in their joint discomfort that is significantly, positively out of proportion to the weight that they lose, simply because they're decreasing that inflammation from decreasing the amount of glucose attached to the cartilage in their joints.
Interesting. I know I've noticed that if I eat some things I'm not supposed to, I go on vacation, indulge, I'll start to feel that kind of puffy,
Yeah,
inflammatory response, and my fingers will hurt, and that my feet, of all things, will hurt. And I'll know right away, okay, clean it up. This is not okay. This is inflammation.
yeah, absolutely. I mean, there's just so many reasons. I mean, we can almost kind of go on and on here. Blood sugar variability. It's not only the absolute high levels, but it's the variability that takes place. And the classic recognition of that is the sugar high followed by the sugar crash. But my patients, and some of this is just anecdotal, but when you have I had a patient last week. um, who went off the rails a little bit. She's pre-diabetic, actually probably diabetic now, but so she went out to like Church's Fried Chicken or something. And people, don't realize that, there's so much breading around that,
Hmm.
stuff that it's a big carb intake. And then, of course, that stuff is cooked in all fast food is cooked in seed oils, which should be avoided. Um, she spiked to 250. She was at like 120. She spiked to 250. And then within an hour and 15 minutes, she dropped to 50. So the physiology of what's happening there is you get this big carb load, because blood glucose in your system immediately. The pancreas releases insulin, but the insulin often overshoots the mark. So too much insulin got released, and that drives the
Mm.
blood sugar down. And that creates the variability and the sugar crash that we're talking about. But that kind of variability between 250 and 50, which I don't see that unoften, results in things like just generalized fatigue and sapping your energy. And I believe it does go so far, though it's a generalized term, to cause this brain fog and lack of clear thinking processes. And with my patients, when we use the CGMs and we level those curves out so there isn't quite as much variability, that they do better in that regard as well.
I was just about to ask you that connection to the brain. What
Yeah.
is that glucose doing to the brain? And we've heard there's connections now, dementia, Alzheimer's. Can you speak into that a little bit?
Yeah, yeah. There's a new book out. If people want to look it up, I need to plug my book too. Um, but uh, but there's a new book out by a Harvard-trained psychiatrist by the name of Chris Palmer, and he is doing research that is linking um, degree of blood sugar, your elevation of blood sugar, to a number of mental issues. And this makes perfect sense. And I don't know if you know this, but the original use of the keto diet, basically low carb diet under 20 grams a day or so, the original use of the keto diet was to control pediatric seizures. So this is back in the day, 30s and 40s, before there were medications to control seizures. And it was found that if you restricted kids, and I'm talking about, little kids, 4, 5, 7, 12, to a keto diet, that the frequency of their seizures decreased dramatically. That approach is actually still used in some major centers, along with medicines, is to put kids on a keto diet to help control their seizures. So Chris Palmer's work is that with that foundation of knowing that your level of blood glucose and ketones impacts your brain health, it can impact other things. So he believes, for example, and I think a lot of this is still under study, so I don't think people should go crazy with it, but I believe there's something to it, is that being on low carb or keto can actually improve mental health disorders like depression and anxiety, as you alluded to, can decrease the risk. I think this is unquestionable, of dementia long term, because there's a lot of vascular disease in the brain. I see it every day when I order CAT scans on patients in the emergency department. It's called microvascular disease. It's considered what's called an incidental finding, which means it's not the reason that the patient might have their headache or whatever, but all day long I see patients, 50s, 60s, that have microvascular disease, which means they've already got problems with clogging of their small arteries in their brain. And of course, that leads to dementia. But Dr. Palmer is, pursuing a line of research related to mental health issues and dementia, and it to me just makes sense that there would be a connection there.
Yeah, agreed. I mean, I know our brains need glucose, but in excess, it's bound to be toxic at a certain point.
Absolutely, that's a good way to put it.
Well, this has been really enlightening and educational. I know my listeners are going to be receiving so much value from this. As we
Good.
begin to wrap up, was there anything I know we could go on about this a long time, anything we didn't cover you'd like to mention? And then
Yeah.
letting the listeners know how they can find your book, how they can work with you, get a hold of you, follow you.
So a lot of what we just talked about is in the book. Okay. And I know your readers or listeners can't see this, but it's the continuous glucose monitor revolution for non-diabetics. So this is focusing on using CGMs in non-diabetics and pre-diabetics. Oh, I got to make one mention of one other clinical thing. If you're pre-diabetic, lights and sirens should be going off because you can reverse prediabetes and never become diabetic. So that's a critical time. It means you've got some insulin resistance, and now's the time to reverse it to ever progress. So to diabetes. So if you've got prediabetes or diabetes in your family, or you're overweight, get a handle on your insulin resistance. A lot of unfortunately mainstream medicine is kind of like, oh yeah, you're pre-diabetic. We'll keep an eye on it. I think it's a huge deal. I work with lots of patients to help reverse their prediabetes so they can avoid ever becoming diabetic and having the complications of diabetes. So I got distracted, but I wanted to throw that in. So the continuous glucose monitor revolution for non-diabetics, it's the best-selling book on Amazon related to continuous glucose monitoring. It's digital book, audio. If audio, I did the audio. If you can stand listening to me for 6 hours, um, or paperback, and there's a hardback too. So I appreciate your listeners having a look at that. And then my practice, which really does what we discussed here, and provide people some guidelines, get them CGMs as well. Sees patients in Ohio, Indiana, Florida, and Arizona. I have offices in Ohio and Indiana. I see people in the office, but quite honestly, for this type of practice, most people are preferring a telemedicine type practice, and I
Mm-hmm.
see the vast majority of my patients via telemedicine. And so we can, do the telemedicine visits. My health coaches do telemedicine. We provide, health coaching support. We can, remotely monitor their CGM data. And we do a structured program that generally initially lasts about 6 months, and then a lot of people just stay with us at a maintenance level with less frequent visits long term. So if any of your listeners have an interest, please look at the book. And then if you have an interest and you think I might be able to help you with this type of program, again, Ohio, if you live in Ohio, Indiana, Florida, and Arizona, get a hold of us. Also, I do have, I must say, I do have people that actually, the medical board rules are such that the patient has to be in the state that you're licensed in. So, for example, I can't treat somebody that's in Illinois, but I have a number of patients that actually drive from Chicago into Indiana so we can do their visit together. Again, because it's just a telemedicine visit.
That's great. Thank you so much. I want to ask one quick thing. What if one of the listeners doesn't have a weight issue, but they're concerned about their metabolic health? Do you work with these individuals as well?
Absolutely. It's a minority of my patients, but I have a lot of patients that come that again don't have weight issues, but they still have some insulin resistance. They've been told that, their cholesterol is a big, cholesterol of 220 with, maybe HDLs, good cholesterol that is good. So I do work with that population of patients. A lot of those patients have educated themselves significantly before they've come to me. But for people that just want, if you've got prediabetes in your family, or you have concerns about vascular problems long term, yeah, we can do an evaluation and sort out if you have insulin resistance so you can act on that before it's too late.
Oh, I think that's so important. We all need to be concerned with our metabolic health and not
Yeah,
make those assumptions that, oh, well, I'm thin and so everything's okay, because you know
yeah,
the classic skinny fat, and those individuals
right.
can have fatty liver as well.
Right, absolutely. And there are different ethnic groups that can affect more. For example, Asians are affected more. That's why actually there are a lot of slender Asian people that are diabetic. So that population especially should be looking out for this. But if you've got a history of vascular problems or prediabetes or diabetes in your family, your antenna should be up related to this
Hmm.
risk. Okay, and don't
Absolutely.
don't let your doctor tell you that you need to just focus on your cholesterol level. Cholesterol can be a piece, but again, I'm trying to have people understand the importance of the insulin resistance. and blood sugar.
Yes. Yes,
Yeah.
agreed. Well, Dr. Kolodzik, it's been wonderful speaking with you. Thank you so much for
Thank
being on
you.
the show.
Hey, can I plug my website if anybody wants to learn more is Metabolic
Oh, sure.
MDs, metabolicmds.com. So there's all this information on my website as well. And so you can learn more. And even if you just have a question, be in touch.
Wonderful. Thank you, Doctor, so much.
All right.
And
Thank you very much, Carol.
to our listeners, wherever you are in the world, we wish you every blessing. Bye for now.